Oh. Okay, you are ready to start the meeting?
Yes, sir. Sir, with your permission, sir, Dr. Atish would introduce and we'll begin, sir.
Okay,
Sir.
very good.
Sir, I'll introduce, sir. Whom to introduce, sir?
So, okay, then I'll do that thing, sir. Those who have trained under Dr. Rajesh, any given day,
Sir.
his dialogues and his sayings would be repeated in the lab. That I am very sure, sir, because that is how he has imbibed into our DNA. That whenever we are in cath lab, doing any sort of intervention, we'll remember him once at least in the day. So that is how he has impacted us, and we are very keen to listen to him and throw him any subject, any topic, and you'll have multiple papers from him, and then the gist of everything. So today we are going to get this gist on LMPCI, how imaging would work there. Sir, please.
Yes, Smith, thanks for the introduction, and can somebody help me?
Anyone from Netcast, please help, sir.
I have opened up my PowerPoint at the desktop. So
Yes, sir. We can see, but sir, we are seeing a window which has this same camera thing, zoom thing on, sir. You have to select another window where the PPT presentation would be there.
Entire screen share and can.
Sir, pick not entire screen, sir. Pick one window where the PPT is open.
Okay, just hold on. Chrome window. Okay. So here is the window.
So you will have multiple choices. Wherever the PPT is displayed, sir, you can pick that.
So let me double click the window. I'm not able to double click, but let me share it. And are you able to see it now?
Sir, just move to the PPT, minimize it and open the PPT, sir.
Yeah, then I think we'll be able to.
I have opened up the PPT. Are you able to see it now?
No, sir. Just stop it, sir, once.
Okay.
And now click on share and select entire screen.
Select entire screen. Here is the entire screen, and let me share it. Okay, and now?
Now move to the PPT. Open the PPT on your.
Okay, I have opened up.
Yes, sir. It is visible. Now make it
slideshow. It is visible?
Sir, full screen. Yeah.
Okay, that's fine. So are you able to see?
Yes, sir.
And also listen me very well. Very nice. Thank you. So thanks, Smith, Sajatya, and the team to invite me for this particular lecture on role of imaging and functional assessment for LMPCI PCI. The question arises: what is significant LMPCI lesion? Any angiographic stenosis of more than 50% been considered as a LMPCI disease. However, angiography we have certain limitations. Those with the angulated LMPCI, non-coaxial engagement of the LMPCI, lack of reference segment when the LMPCI is diffuse disease. And you never know about that, what is the main diameter, diameter of the LMPCI whenever it is diffuse disease. Port shortening, eccentric lesion, reverse tapering are certain other phenomena by which in such situation you are not able to assess whether there is any significant LMPCI. Sometimes there is a catheter-related spasm, and you wrongly interpret as a hostile LMPCI disease, and also a non-selective convolution and streaming of dye. So there are various reasons. There is an inter-observer variation. Angiographically normal LMPCI may have a significant LMPCI disease, and vice versa. And therefore, here comes the role of functional assessment and intravascular imaging to define whether there is a LMPCI disease or not. and then appropriately go ahead for the revascularization. So here in this slide, you can very well appreciate the first angio is about the ostial left main. There is a damping of the pressure, but then FFR is 0.89 and the MLA is 7.82 millimeter square on the IVUS. So there is no significant left main disease. On the other side, the other angiogram do show that the left main otherwise is seems to be normal angiographically, but then an OCT has been done across the left main to LAD, and you can very well appreciate a calcified nodule, and then the MLA is 3.55 millimeters square, which is a significant left main disease, and therefore require the intervention. What are the indications for the left main PCI? Any left main stenosis which is more than a 50 to 90% stenosis with documented ischemia is the one which is supposed to undergo the revascularization, or otherwise a FFR less than 0.8 or minimal luminal area of less than 6 millimeter square on intravascular imaging, whether it is IVUS or OCT. What are the indications for the left main? As per the ESC guideline, it's a class 1 indication in case the syntax score is less than 22. More than 22 is the one where the surgery is preferred. ACCH is still to considered patient with the left main and syntax score less than 20 as second B indication for the PCI. But it's very important to have a hard team approach for each and every individual left main case to decide about which is going to be the best, whether it's a CABG or PCI, even if the syntax score is more than 22. As usual, the intravascular imaging, like for the other PCI, is helpful for pre-procedural planning, intra-procedural guidance, and post-procedure optimization. This particular slide is well known for those who are doing the intravascular imaging, and then you have to assess the MSA, which should be more than 80 to 90% of the reference diameter, whether it's a proximal or the distal. There should not be any malopposition. It should be less than 400 micron. A distance of less than 1 millimeter. No extensive protrusion. Distal landing should have no plaque burden, which should be less than 50%, and there should not be any significant as dissection, which includes a less than 60 arc of dissection, flap which is limited to intima, not extended to media, and the length of dissected segment is less than 2 millimeter. This is a very frequently quoted study from the South Korea with the rule of say 5, 6, 7, 8. The LCX is minimal luminal area, which should be there for the revascularizing should be less than say more than 5. For the ostial LAD, it's a 6, confluence is 7 and 8. And this particular rule of say 5, 6, 7, 8 is based on a study again from South Korea where 403 patients treated with a single stent in 72% of the patients and 2 stent with 28% of cases. And it's the 9-month angiographic ISR prediction on the basis of this particular formula. In case the MLA is less than the particular area, it's likely to have a 9-month angiographic restenosis. However, if you talk about the long-term outcome of the left main PCI, this particular study again from the Korea about the 2-stent technique for the left main bifurcation disease and 5-year clinical outcome. So it's a 292 consecutive patient of the left main being treated with the PCI and the final MSA at the ostial LAD, ostial LCX, and distal left main being calculated. And what's been found at 5-year of follow-up, those with the distal left main of the area less than 11.8, LCX less than 5.7, and LAD less than 8.3 have now adverse outcome at 5-year follow-up. So this is going to be a newer formula of the left main revascularization with the 2-stent technique of 6, 8, 12. The minimum luminal area should be across the L6 should be more than 6, more than 8 for the LAD, and for the left main, it's going to be 12 millimeter square. Now, what do the trial says about the role of intravascular imaging for the PCI, specifically for the left main? Renovated complex PCI and with a subgroup analysis of 192 patients of left main disease, where the imaging was done in 138 patients and the OCT was done in 6.5% of the cases. Rest had the IVUS imaging. There was a significant reduction in primary endpoint at 3 years of follow-up, which includes cardiac death and target vessel related myocardial infarction. And then it's been found that there is 84% risk reduction in case you are going to use the intravascular imaging compared to angiography alone. So this is very important conclusion of this particular study, that left main is the one where there is a need to have an imaging during the PCA. Otherwise, there is a very significant risk of the maze at follow-up. So there is usually in various conferences, people do ask about that, okay, in case there is no imaging, how to go ahead about the left main PCI. I would say with the outcome which is so adversely been affected without the imaging, it's preferable and it's recommended to go ahead with the left main PCI along with the imaging, and one should not go ahead without the imaging for the PCI. We do have an Illumin 4 randomized trial, which though has not shown the favorable result at 2 years of follow-up for the complex coronary lesion, which doesn't include the left main. There was a bifurcation lesion in 3.3%. We were fortunate to be the part of this particular study from the PGI. And then what important thing or conclusion of this particular study was that a minimum stent area of more than say 5.7 is the one which is associated with a favorable outcome compared to angiographic guidance, which has an area of 5.36. And it also do translated into stent thrombosis, which was significant in angiography guided PCI compared to OCT guided PCI. Then we had now October randomized trial, 1200 patients with the complex bifurcation lesion, which includes 19% patient with the left main bifurcation. And at the 2 year of follow-up, there is a significant improvement in the maze. It was far better compared to angiography guided PCI. This is another study, a prospective single center study from the Spain, where the three groups were there. One is angiography guided, second is the IVUS guided, non-protocol IVUS guided PCI, where one has to look on whether there is a significant, say, MSA across the LAD, LCX, and the left main. And another one is the IVUS Pro. It's a protocol IVUS guided left main PCI. And what's there in the protocol for the IVUS guided PCI is that one is supposed to have now left main minimum luminal area, which should be 90% of the distal left main reference. It should not be, say, more than 80%. There is complete opposition and no deformation. Stent edge should have less than 40% plaque burden, no dissection and a hematoma. And it is expected to have a 90% expansion of the distal reference for both ostial LAD and also the X and the left circumflex. Post dilatation and the final IVUS check was mandatory. So what has been found that those with the protocol, IVUS Pro protocol, had a higher MLA, higher MSA, that is 11.8 millimeter square, compared to those with the routine IVUS, which is 10 millimeter square. The IVUS Pro had an 88% expansion criteria, while routine IVUS use had a 64.5% criteria of stent expansion. And see what impressive thing is about that primary endpoint at 12 months, angiographic guided is 12.9, IVUS guided is 8%, and IVUS Pro, when you have looked into the distal reference and then dilated the stent with the balloon to have reference diameter compared to reference diameter, the MSA of say more than 90%, the IVUS Pro had now 4.8% primary endpoint at 12 months of follow-up. So this is something impressive, and therefore one should have an optimal result even with the IVUS use. And now question comes for the left main, whether it's IVUS or the OCT. Yes, IVUS has definitely shown the advantage, mortality and morbidity benefit with the left main PCI for a long time, but then recently there are few studies about the role of OCT for the left main and the complex lesion being supported with the OCT imaging. So this particular study about the seven major study, which includes the four randomized and the three observational study, which include the OCT in 2,000 patients and I was in 3,800 patients. And what's been found, OCT guided PCI, there is no statistically significant difference for all these outcome groups, which include MACE, cardiac mortality, all-cause mortality, myocardial infarction, stent thrombosis, target lesion revascularization, and also the stroke. On the basis of this recent trial, there is a ESC new recommendation for the role of intravascular imaging for the PCI being considered as class 1A, which includes the complex lesion, left main, true bifurcation, and long CTO lesion. So these are the primary indication to go ahead for the intravascular imaging during the PCI, and of course the indication is class 1A. So this particular case, angiographically, if you see, we had a left main to LAD provisional stenting. It seems good, but the OCT did show a significant dissection into the left main proximal to the stent and for with an additional stent being put. So here comes the role of imaging for the left main. Angiographically, we would have missed the ostial or proximal left main dissection, which could be nicely picked up with the OCT imaging. And then you can very well define whether it's a complex or simple dissection. Here, as per the definition, more than 60 degree, more than 2 millimeter, and depth extended to the media is the one which required another stenting, and therefore we went ahead with the additional stent into the left main ostium as well. This particular case, we had Natavi done, and then there was the acute occlusion of the left main. Patient got deteriorated, for which we had a two stent, bail out the stenting and could restore the flow across the left main. 6 months at follow-up, there was an instant restenosis of the ostium of the LCX, otherwise the LAD is flowing well, and therefore we went ahead with the intravascular image-guided PCI, and here, to our surprise, this is the left main stent which is protruding into the aorta as well, as you are supposed to have a so-called chimney stent following the tower to extend the stent proximally, and we had a stent fracture across the left main bifurcation, which could be nicely demonstrated in this IVUS run from left main to LAD. You can appreciate part of the stent is not there from say 12 o'clock to 5 o'clock in this IVUS run, and it got crumpled on the another side. So this was treated with another left main to L6 stenting, and now it's around 2 years of follow-up, which it is doing well after the last left main to LCX crossover stenting, and we could publish this particular case in Cath Cardiovascular Intervention as well. Something about risk of side branch occlusion, how to have an idea about for the left main bifurcation that we are likely to have an ostial L6 occlusion. So there are certain risk factors which can be nicely identified, and one can have an extra precaution to take care of the L6 as a side branch in case and in case there any occlusion, one can treat it accordingly. So what are the various risk factors to a side branch occlusion which can be assessed by the intravascular imaging? These are the various as per these studies. Plaque distribution opposite to side branch ostium is the one. Carinal tip angle of less than 50 degree. Carinal tip to bifurcation point length of less than 1.7 millimeter. A bifurcation angle less than 70 degree. PCI percentage diameter stenosis of side branch and main branch calcified plaque are the shown, and in case it's a hyperlipidic arc of more than 90 degrees. So these are the various factors which has been associated with the side branch, that's the L6 occlusion during the left main PCI, and therefore one has to be very careful. So this particular lady, 35-year young female with the ACS and the osteal LAD, and if you see the angle between the LAD and the L6 is 45 degree, and the angle angiographically which is less than 50 is the one which has the risk of side branch, that's the L6 occlusion, and then we had pulling balloon dilatation. This is what the OCT run across left main to LAD, and then here you can very well appreciate the CT angle is 39 and CT bifurcation point length is 1 millimeter. So less than say 70-degree angle, and the less than 1.7 millimeter is the length which do predict the risk of the side branch, that the osteal L6 occlusion. And then after putting a stent from left main to LAD, you can very well appreciate there is a pinching of the side branch osteal LCX occlude over here, secondary to the plaque shift, and then it was successfully treated with the kissing balloon inflation. Regarding the rewiring of the side branch following main branch study, as you all know, there is a need to have a distal stress crossing whenever you do go ahead for the left mid to LAD standing to another stand or the balloon dilatation across the LCX, and then angiographically to go ahead distally versus proximally with so-called fluoroscopic guidance, the success rate is around 55 to 65%, while the OCT with the 3D reconstruction, the success rate goes to increase to say 90 to 100%. And this is the 3D reconstruction of the OCT, which nicely define about at which side you are crossing across the bifurcation point, whether it's a distal or proximal distal. It's very important to look for a link-free carina at the bifurcation point, just to have a less of metallic neocarina when you are going into the left main bifurcation stenting or provisional stenting from left main to LAD. This also to help to have a wider side branch opening. So this particular case, left main to LAD stenting been done. And then just for the final kissing, I was crossing the wire from fluoroscopically, proximally versus distally, which is difficult to assess. And then you can appreciate in this OCT run, 3D reconstructed OCT run, the upper three are the one where there is a proximal crossing. You can nicely appreciate how the proximal crossing is very well visualized across the left main bifurcation versus the lower three run are the one where you do have a distal procedure. Here, the imaging, especially the OCT with the 3D reconstruction, do help to have an idea about whether you are going distally or proximally. Something about what is the threshold for side branch stenting whenever you are going ahead with the left main intervention, any lesion of the LCX which is more than 5 millimeter, like the complex bifurcation, FFR less than 0.8, and the MLA across the osteal LCA, which is less than 3.7, is the one which requires the revascularization for the left circumflex, otherwise not. Sometime these two study has nicely demonstrated that angiographically a significant LCX has an FFR of less than zero point 0.8 in only one-third of the patient. Two-thirds of the patient, though having the angiographically significant stenosis, doesn't have a FFR in case somebody is going to calculate across the LCX ostium of say less than 0.8. So this is very important to have a functional assessment of the side branch before going ahead for a complex two-stent stress for the left main bifurcation disease. And what happened in case you have jailed the LCX and the FFR is say less than 0.8 or more than 0.8? This particular study has demonstrated that in case the LCH FFR is less than 0.8, the 5-year target lesion revascularization is going to be on the higher side compared to those with the FFR of less than 4 FFR of more than 0.8. So this particular case, we had enlargement to LED stenting, pre-PCI, we assessed the ostial LCA, the MLA was 6.12 millimeters square, and then FFR was 0.96 post PCI, though angiographically it seems there is a significant plaque shift and a significant stenosis across the ostial LCX, but then we had an MLA which is 6.04 millimeters square and FFR which was 0.96. Pre-PCI is now 0.89. So therefore, there is no need to go for any intervention for the ostial LCA. Are you able to hear me?
Yes, sir, you're audible.
You're audible.
Okay, just
Audible.
hold on. I'm not able to move my slide. Okay. So now regarding the functional assessment for left main PCI, are you able to see my slide now?
Yes, sir.
Yeah, you are
Okay.
visible.
Yes, sir.
Very nice. So this is regarding functional assessment of the left main PCI. Instead of say intracoronary bolus infusion of the adenosine, it's a preferable to an intravenous infusion of adenosine to an assessment of left main significant lesion. The appropriate ischemic threshold is not very well defined for the left main. It do vary from say 0.75 to 0.80, and then there is a technical problem with the left main in case there is a bifurcation disease involving the LAD and also the left circumflex, where the pullback gradient has to be looked into, and it's going to be erroneously increased when there is a disease distally into LAD or LCX. There is a lack of randomized data about the long-term safety of the FFR across the left main bifurcation when there is a disease across the LAD and LCX also. So this particular case, a left main bifurcation disease, which with the LED and the LCA, which is having around 60 to 70% disease, and distal left main is also having some disease. And then we had FFR done, so LED is 0.58, L6 is 0.73, and left main is 0.73. Hence, there is a significant functional stenosis of the left main bifurcation, and therefore this particular patient underwent the two-stent left main bifurcation (PCI). So, with the limitation of the FFR across the left main, this particular study has assessed the IFR across the left main, which doesn't require any hyperemia, and then IFR of less than 0.89 was treated with the revascularization versus those with the IFR of more than 0.89 continue on the medical treatment. And then at 50 months of follow-up, both the arm has the similar outcome, similar endpoint, and therefore it's a safe to defer a left main revascularization a patient with a left main who is going to have an IFR of say more than 0.89. What about the FFR in ambiguous left main lesion? This particular meta-analysis of 6 prospective cohort study involving 525 patients has shown that a FFR value of 0.75 to 0.80 has shown that there is no significant difference in means all-cause mortality or non-fatal myocardial infarction at the follow-up 26.5 months in case we do defer a left main in case it is having a FFR of more than 0.8. However, there is a significant subsequent revascularization in deferred patient compared to those who has been revascularized. What about the intravascular imaging for the ambiguous left main? As I mentioned about the ML of less than 0.6 is the one which has to be revascular, and those with the more than 6 millimeter square is the one which has to be deferred for the revascular and continue on the medical treatment. There are certain studies from South Asia where the cutoff point instead of 6 millimeter square is 4.5 to 4.8, but then this data is not been validated. So still we do consider less than 6 is the one which is supposed to undergo revascularization. A literature study from the European countries has been published, which is the prospective multicentric study involving 354 patients, and this is the MLA of 6 millimeter square, which was clinically validated and had 2 years of follow-up. The outcome in those who were revascularized versus those who were deferred has the similar outcome. So finally, it's imaging a class 1 indication for the left main PCA as per the ESC guideline. IOS has proven the safety and efficacy in the left main PCA. It is preferable for left main PCA and those at high risk for the contrast-induced nephropathy. OCT do better define about the post-PCI technical complication like major dissection, malopposition, tissue protrusion, and geographical risk. And all these parameters are associated with the stent failure, whether it's a target vessel failure or stent thrombosis, has been demonstrated in element 4 study. OCT do better define the bifurcation lesion, its geometry, plaque distribution, and also the appropriate rewiring of the side branch has been demonstrated in one of the case. And this particular data is supported by the October randomized trial. Finally, a combination of imaging and functional assessment should be a ultimate goal for those who presented with a complex left main bifurcation lesion. Thanks for kind attention. Okay, any comment, please?
Thank you, sir,
Yes,
for
sir.
enlightening us and revisiting to your teaching, way of teaching, sir. It's always very methodical and it dissects out whatever we wish to. Actually, just the gist of the things. सीधी बात नो बकवास वाला.
Thank you very much.
Rajesh, that's a very good talk. Always remember your lectures. You have your special style, and very conclusive and affirmative way you speak is what I really appreciate. What special precautions? Of course, this is a vexing question. What special precautions you will take for FFR at LM ostium? I'm sure many people address this, but what is your take?
So whether it is FFR, means you are supposed to cannulate and then remove the catheter during the FFR. The guide catheter has to be in the aorta instead of the ostium, just to avoid damping and restriction of flow across the left main ostium. Same is then true when you are going to do the imaging, especially the IVUS. The catheter should be in the aorta instead of the left main ostium to have now appropriate finding. For the FFR across the left main, I would say, and it's also been recommended that intracoronary injection is not preferred. It's going to be intravenous infusion to have the hyperemia and then to assess the FFR across the left main. So that's one thing. Most of the time, we do go ahead with the intracoronary injection of the adenosine, either 200 or 300 microgram, and to look for FFR value, which is not the same for the left main. And then, of course, the LAD and LCX, in case it's going to be diseased, there is enormously higher FFR value across the left main, and therefore, either you can go ahead and have a revascularization of the LAD and LCX, and then look for the FFR across the left main, whether it's on the higher side or not, and decide about. So In such type of situation, one can very well go ahead for the IFR to look for whether there is need for revascularization or not. Otherwise, also, as you are going to have imaging across the left main, instead of totally relying on the FFR, one can very well have a look on the MLA across the left main bifurcation. And in case it turn out to be less than 6 or plaque burden is more than say 70% is the time when instead of going for the osteolytic or osteolysis, preferable to go ahead for the left main revascularization as well.
Thank you, Dr. Rajesh, for your nice, excellent, educative lecture. Whether
Very good.
non-hyperemic functional indices is better in bifurcation left main lesions compared to ischemic
FFR.
indices because of its false negative values. Is it any
Right.
comparative studies?
There are no comparative study between say FFR versus IFR for the lab man, but then of course for the other lesion they are the study, and then positive predictive value of the two is around 85 to 90%.
Okay, right.
Good evening, sir. Swajate here.
I said it.
Hi, sir. So sometimes after in the LAD, after stenting, we find the is fine, but the LAD ostium looks like a D rather than an O. So, and sometimes, although area-wise it might just be creeping up over 8, but it looks like it's D-shaped or oval-shaped and doesn't look like the perfectly O-shaped. Is it significant in the long run, or do we need to again go aggressive and try to achieve a spherical sphericity, which is called sphericity index?
No, main important thing is regarding the eccentricity. I would say the MLA is more important compared to eccentricity. This is a concern when you are dealing with the calcified lesion. Otherwise, whether it's a oval or spherical, I would say the MLA, which is that's what I have mentioned. 8, 10, and 12 is the one, and they should be the minimal luminal area. So instead of going out for the oval or spherical, it's the MLA which is important to look for the for during the imaging for this left main bifurcation disease.
Right.
Sir, Ratish here, sir.
Hi, Ratish.
Sir, regarding the ostial left main, sir, how will you be able to see clearly with OCT, sir? I mean, is there a technique where you can clear the ostial left main?
So regarding the osteal left main disease, it's a preferable to have an intravascular ultrasound instead of the OCT. For the OCT, one is supposed to cannulate the left main to have an adequate result. Though I have done few cases, but then it's only 1/3 of the patient where you can very well visualize the ostium of the left main with the OCT. So it's a preferable to go ahead with the IVS instead of OCT. That's one thing. In case you are going to extend the stent at the ostium of the left main and then cannulating it with the guide catheter to an appropriate OCT imaging, there is a risk to an stent deformation as well compared to what the IVAS is. So you can safely put the guiding catheter into the aorta to very well assess the ostium of the left main with the stent in C2.
Sir, there is one question. So, in left main to LED provisional stenting, if there is a significant pinch at the circumflex ostium and functional study is normal, suppose 0.90 above, so would you like to go with some imaging, or would you like to open the struts, or just leave it like that if it is normal, FFR is normal?
So see, with the FFR, which is point 0.9 across, I'll say it doesn't require any intervention. And here, to go ahead with the intravascular imaging is not advisable until or unless you have dilated the side structs. Okay. Otherwise, there is a risk to an imaging catheter entrapment when you are not having a balloon dilatation across the LC. So that's one thing. In case you are able to demonstrate the FFR value of 0.9, then there is no need to go ahead for side branch dilatation. That's one thing. Regarding provisional standing from LAFMAN to LED and to go ahead for final kissing or not, to have just dilatation of the side branch ostial L6 tracts is debatable. We are doing the multicentric trial of the LAFMAN to look for the clinical outcome of no kissing versus kissing across the LAFMAN following the provisional extending from LAFMAN to LAD. Result is not out, and then hopefully, as we are doing the multi-centric trial, along with few of the centers from the south as well, Ankush is supervising it. So we are going to have the answer very soon about whether to go ahead for the final kissing or not. There are not many published studies which doesn't favor to go ahead for the final kissing after the provisional stenting until and unless you do have the LCX, which is having a functionally significant uh, finding across say FFR more than 0.8.
I think that also answers the question in the chat box by Dr. Orgo. Yes, sir.
What's the question, Sujata? Can you?
Sir, it's about whether to kiss or not to kiss for provisional strategies in left main.
So that's we are doing it. There are two school of thought, but then by now I think we have enrolled around 500 patients from the multicentric trial of Ram. Are you a part of it?
No, sir, I am not part of it.
Okay. So let's see how the data is going to be there. The only advantage is that in case there is any future interval, you can easily go ahead and pass across the LCX. The disadvantage is going to be in case you have done the heterogeneous dissection across the LCX, then you are supposed to put an additional stent. But in this multicentric trial, which is ongoing, and I am part of it, what we are doing is to have the final kissing in those who has been randomized for the kissing balloon dilatation with a balloon which is 0.5 millimeter lower the size of the ostial LCX. And at the baseline, we are doing the imaging of both LAD and LCX to have to assess the reference diameter of both the vessels to decide about what type of balloon is going to be used for.
Sujata, any more questions?
Not that I can see, sir. There is only one question that was there. And yes, sir.
So if there are none, you can conclude.
Sir, Dr. Sarath Chandra, or you can maybe give some concluding remarks about this. Okay.
I think sir has got disconnected.
Oh, okay. So I'll conclude then, sir. Rajesh sir, with your permission. So it was, as usual, a very exhaustive and very informative lecture. And we, as always, are very grateful that you support us and you always are ready with to take this master class. And I hope we have more informative lectures from you in the future as well. And thanks to Dr. Kaparti sir, Dr. Sarath Chandra sir, and all the participants for joining in, sir. And yes, sir. With that, if with your permission, we can conclude this now, sir.
Yeah.
Please.
And Ram sir, what about our meet?
Yes, if Ram sir can give some advice about that.
Yeah, due to this NIC, which were the dates which we decided in second week of April, so we have discussed that we have to postpone this meeting, and now the Rajasthan is very hot from April to June. So we are planning to do it in July, second half of July.
Okay. Great, sir.
In monsoon,
Because
monsoon will be much better.
Yeah,
Oh.
you were asking about it.
Yes.
Thank you.
Okay, thank you everyone. Let me enjoy the dinner and the party over here.
Thank you,
Sir,
sir.
good
Thank
night,
you
sir.
very much.
Thank you.
Thank you.
Great, sir.
Okay,
Good night,
thanks.
sir. Thank you,
Thanks.
sir.
Rajesh and Smith.
Nice to see you all. Okay, bye.
Thank you.